A young man is involved in a motor vehicle crash. He is badly injured. At the scene, he says he can't move his legs. When he arrives in the hospital, both his blood pressure and his heart rate are low. This patient needs urgent resuscitation, but consideration must be given to neurogenic shock. An introduction to critical care, presented by me, your host, Pat Nelligan. Cardiovascular assessment, the blood pressure. This tutorial is on neurogenic shock. This time I will discuss very briefly spinal cord injuries, the pathogenesis of neurogenic shock, and the management of the patient with neurogenic shock. Let's start with a clinical scenario. Brian is 27, he's a motorcyclist and he's hit by a car. He's unable to move his legs at the scene and he's brought to the emergency department with full spinal precautions. It is likely that Brian has had a spinal cord injury. Spinal injuries involve damage to the spinal column and its contents. The spinal column stretches from the base of the skull to the coccyx, the spinal cord to the lumbar vertebra, where it splits into the cauda equina. If we look at a cross-sectional image of the spine, there are a few structures that you must be familiar with. First are the spinous processes. These are the bumps that you feel when examining the back. Then there is the vertebral body. This is a relatively large bony structure that takes the weight or load of the rest of the body. Each one is separated by a shock-absorbing intervertebral disc. In the middle of this is the spinal canal filled with cerebrospinal fluid. And floating in this, traveling from the base of the skull to the lumbar vertebra, is the spinal cord, from which spinal nerves originate. These are motor, sensory, and autonomic nerves. They pass through bony canals alongside blood vessels to exit the spine. Most spinal injuries are caused by either the vertebral body moving, that's dislocating or subluxing and damaging the cord, or the vertebral column, usually the vertebral body, or its associated structures, shattering or bursting, and spicules of bone impinge, compress, contuse, or lacerate the cord. The most common form of injury is impact plus compression, burst fractures with bone fragments compressing the spinal cord, or fracture dislocation. Sometimes distraction injuries caused by hyperflexion or hyperextension cause two adjacent vertebrae to be pulled apart, stretching and tearing in the axial plane. Laceration or transection of the cord is much less common than you might imagine. It happens with missiles, projectiles, etc. in combat, severe dislocations, or large bony fragments. I'm going to illustrate this now by looking at a longitudinal section of the cervical spine from C4 to C7. These are the vertebral bodies and the intervertebral discs, and on the left are the spinous processes. The blue tube is the spinal cord. Now, there are four major mechanisms of spinal cord injury. These are related to rotation, hyperflexion, hyperextension, or vertical compression. There is impact plus transient compression or contusion, dislocation, distraction, or compression. Returning to our longitudinal view. Blunt force trauma seen in motor vehicle crashes, such as what Brian likely incurred, or falls or sports injuries, particularly rugby or American football, or diving accidents, may jar the vertebral disc in and out. This results in a contusion of the spinal cord. The degree of physiologic and anatomic derangement depends on the degree of injury, as does the prognosis, but many patients make partial or full recoveries from this injury. But major and persistent blunt force to the vertebra may result in a dislocation, with significant stretching of the spinal cord and significant damage. The spinal column must be realigned urgently. Hyperflexion, and in particular hyperextension of the spine, may result in a distraction injury where the spinal cord is excessively stretched. And finally, a compressive effect where one or more vertebral bodies collapsed or burst due to trauma, osteoporosis, or cancer will result in retropulsion of bony fragments into the spinal canal, impinging on or entering the cord. Each one of these cases requires urgent surgical stabilization. When Brian is assessed in the emergency department, the staff will likely fill out one of these forms, the ASIA system, to identify the degree of neurological loss, and he will have extensive imaging of his spine to identify the level or levels of injury. The neck will have been immobilized by the paramedics. He will be transferred on a flat spinal board and log rolled. Let's look at the clinical consequences of spinal cord injury. The spine is divided into 5 segments, each of which has its own distinct features. Each level is characterized by a vertebral body, spinous process, and varying sized transverse processes. There are 8 neck vertebrae, the cervical vertebrae, where 50% of spinal injuries occur. There are 12 thoracic vertebrae, where 35% of spinal injuries occur, 5 lumbar vertebrae, where about 10% occur, and the remainder occur in the sacral or coccygeal area. If the patient incurs a high cervical spinal injury between C1 and C5, this is absolutely devastating. The patient will be quadriplegic. There will be respiratory failure as the diaphragm is innervated by C3, C4, and C5 spinal nerves. There is loss of sensation below that level, shock, and bowel and bladder dysfunction. The patient requires full assistance. Lower cervical spinal injury will spare the diaphragm, but otherwise the injuries are equally life-changing. There will be lower limb paraplegia, some upper limb motor activity. That's very variable. There's loss of sensation below the level, with autonomic dysfunction characterized by shock, bowel and bladder dysfunction, and the patient will require a high level of assistance. High thoracic spinal injury between T1 and T4 will result in lower limb paraplegia, loss of sensation below the level, autonomic dysfunction characterized by bradycardia, I'll get back to that in a minute, bowel and bladder dysfunction, and moderate levels of assistance. Low thoracic spinal injuries are less devastating. This is between T5 and T12. There will be lower limb paraplegia, but the upper limb, the diaphragm, and the cardiac function will be left intact. There is loss of sensation below the level, autonomic dysfunction involving the bowel and the bladder, and the patient will require a wheelchair. A lumbar spinal injury between L1 and L5 will be associated with paraplegia, but with variable movement depending on how high up the injury is. There is sensory loss below the level. There will be some autonomic dysfunction involving the bowel and the bladder, and mild dependency. Let's go back to Brian. Unfortunately, Brian had a C7-T1 injury. He has some movement of his arms and legs, but he has become profoundly hypotensive with a blood pressure of 80/40 and a heart rate of 40. Brian has neurogenic shock. Neurogenic shock was traditionally called spinal shock, but the title has changed due to better mechanistic understanding. It refers principally to autonomic dysfunction caused by interruption of sympathetic control. If you work in critical care or anesthesia or indeed medicine, you need to have an extensive understanding of the autonomic nervous system, and the sympathetic nervous system is involved in a vast array of autonomic functions. It is essential to note that the preganglionic fibers to the sympathetic chain come off all levels between T1 and L1, meaning that disruption of the spinal cord at any level will cause a sympathectomy and autonomic dysfunction below that level. Importantly, during spinal cord injury, it is the preganglionic sympathetic fibers that are damaged. Part of the normal housekeeping of the body is the ability to distribute blood to the muscles, brain, or viscera dynamically, depending on demand. Blood vessels with no autonomic innervation are floppy or unstressed. Normally, though, mild vaso or venoconstriction occurs due to adrenergic activity, and this is known as sympathetic vascular tone. Both arterioles and venules are kept partially vasoconstricted, principally by norepinephrine, that's noradrenaline. Hence, loss of sympathetic output from any part of the spinal cord will result in vasodilatation below that level, and usually that results in hypotension. Importantly, between spinal levels T1 and T4, the sympathetic nerves to the heart, they're the preganglionic sympathetic nerves, exit the spinal cord. These are known as the cardiac accelerator nerves, and they travel out to the cervical and thoracic ganglia and then onwards to the heart. The cardiac sympathetics antagonize the vagus innervation of the heart, speeding it up to a resting rate of about 70 beats per minute. When there is a high spinal injury above the level of T4, that sympathetic innervation is lost and the vagus acts unopposed to slow the heart down to a rate of 40 or lower. This leads to a fall in cardiac output in addition to the vasoplegia from the sympathetic loss to the extremities. And that's why Brian is both bradycardic and hypotensive. Let's summarize the features of neurogenic shock. In all cases, sympathectomy results in hypotension associated with vasodilatation. The higher up the spinal injury, the more vasodilatation occurs because more of the body becomes vasodilated. If the injury is at or above the level of the cardio-accelerator nerves, that's T4 or above, then bradycardia is also a feature, and that's caused by essentially overactivity of the parasympathetic nervous system. So how do we work the problem of neurogenic shock? If there's a spinal or brain injury and the patient is hypotensive, the first question we ask is whether there's a bradycardia or not. If there is, then the patient requires a vasopressor and usually a chronotrope. If there isn't a bradycardia, then you ask whether the patient is adequately resuscitated or not. If they are, then that patient should be given norepinephrine, noradrenaline. If the patient has not been adequately resuscitated, they need a blood resuscitation, that's red cells and plasma and sometimes platelets, and then when you're sure they're resuscitated, the patient should get norepinephrine. It is imperative to ensure that the stress blood volume is restored with appropriate fluids, and that means blood products. Crystalloid, if used, should be restricted in volume to avoid hydrostatic damage to the interstitium, the bowel, the lungs, the pleura, etc. And resuscitation should be guided by hemodynamic monitors using stroke volume, pulse pressure variability, stroke volume variability, pulse contour analysis. Norepinephrine is absolutely the first choice agent these days. It's a vasoconstrictor that maintains cardiac output. Do not use phenylephrine. It's an inadequate pressor and it reduces cardiac output. And vasopressin may be required if vasoplegia follows massive resuscitation and there is neuroendocrine depletion. Now, in the case of our patient who has bradycardia and vasoplegia, it's always worth starting with norepinephrine as it does have mild beta-1 effects and may increase the heart rate. The alternatives include epinephrine, that's adrenaline, or dopamine. Again, you can use up to 0.04 international units per minute of vasopressin if necessary. You may be asked to administer methylprednisolone to your patient with neurogenic shock, but that is no longer supported by current evidence. Usually, neurogenic shock persists for up to 48 hours and then it gradually recovers as the body regains some degree of autonomic regulation. The higher up the spinal cord injury and the more devastating the injury is, the longer that neurogenic shock persists. In some cases, autonomic dysreflexia persists for weeks and months, but rarely with persistent hypotension. The best outcomes are associated with surgical decompression that is done within 24 hours. Hypotension may also accompany traumatic brain injury, and there are multiple possible mechanisms. For example, damage to the brainstem or hypothalamus causing autonomic dysfunction, Cushing's reflex associated with raised intracranial pressure and dysregulated autoregulation, or a large systemic inflammatory response. We used to call this brain in blood syndrome, where there is widespread release of vasodilator agents directly or indirectly associated with brain injury. The treatment is the same, norepinephrine. Although norepinephrine is the ideal agent for treating neurogenic shock, in the setting of trauma, it is imperative that the patient is fully fluid resuscitated when you start norepinephrine. The reason for this is hypoperfusion is likely to lead to multi-organ dysfunction. Let's review this tutorial. Spinal cord injury is caused by a variety of mechanisms, and they are associated with a loss of vertebral alignment or integrity. The pathologic impact of spinal cord injury is dependent on the anatomic location. The higher up, the worse. All spinal cord injuries may be associated with a degree of neurogenic shock. This is clearly worse the higher the injury, but particularly if the spinal level between T1 and T4 is impacted, because the cardiac accelerator nerves are lost and the patient may develop a bradycardia. The treatment for neurogenic shock is fluid resuscitation and norepinephrine. Occasionally, you'll use epinephrine or adrenaline. That was Neurogenic Shock. I hope you found it useful. If you did, please subscribe at YouTube, follow me at ccmtutorials.org, give me lots of likes and comments, and introduce me to a few friends and colleagues.